So I think the limitations are several. First of all, we don't have optimal targeted agents. Some of the ones we have, we're not really sure what the targets are, even though they're putatively targeting a given mutation. Secondly, that the effects of these drugs are context dependent. So if you have a mutation such as BRAF mutation, which is common in melanoma, about half melanomas, and you use a drug like vemurafenib, which inhibits that mutation, there is a substantial chance of response and benefit. But if you take across the board people with different types of cancer, lung cancer, colon cancer, who may also have the same type of mutation, the drugs either don't work or they work very much less well. So clearly the context, the geographical location of the tumor, its origin, is important. Secondly, as somebody who's old enough to have spent a lot of their career at the time of chemotherapy, there was always the hope when targeted agents would come that they would be much less toxic, and they're not. In fact, although the toxicities are different, so you don't get the acute toxicities, it's the molecular targeted agents are, obviously they're inhibiting pathways, and many of those pathways are needed for normal cell function. So a problem is that many of the targeted agents are quite toxic and they're given over chronic times, and it's very difficult to combine them. So if you have 2 or 3 mutations that are driving a tumor and you want to inhibit each of them, you can't really combine the agents. And tumors are remarkably plastic. They learn to become resistant to the agents that you can use. The biggest problem of all, which has really been a burgeoning area of research over the last about 8 years, has been the recognition of intra-tumor heterogeneity. We've always known that if you compare one colon cancer with another, that they were different genetically. But what has come about from a landmark paper in 2011 and hundreds of papers since, and a very good talk this morning on breast cancer from Nick Turner, was that tumors are incredibly heterogeneous. So when a patient sends off my biopsy and gets my sequence, what they're really getting is a sequence of a little bit of their tumor. And their different sites of disease, if they have metastatic disease, may be entirely different. So it's not surprising that if you attack one part, you might prune a tree a little bit, but you're not going to get profound effects. And this, I think, is the overwhelming difficulty. And it's across the board. It's every tumor that's been looked at has this property where it, as the cells spread from one place to another, and sometimes the treatment that's given itself can drive the changes in genetics and molecular properties. So molecular heterogeneity is the big limitation.